Hey everybody, sorry I'm back. My husband sent me flowers. It's my wedding anniversary today. So we're talking about different anemias, and next we're going to do pernicious anemia. So a little bit for you guys on this one. Remember I told you there are two types of anemia where the cells are big. I think I made a mistake in thalassemia. I'm sorry, they're microcytic, okay? Because of the improper shape with the beta chains. But now we're going to talk about pernicious anemia, okay? And I've started recording, just so you know. All right, so I'm sure. Can everyone hear me okay? All right, pernicious anemia. So we have a stomach here, okay? So this is your esophagus. This is your tube that goes down, okay? It's kind of a big stomach, but oh well, okay? This is kind of what your stomach, kind of what it looks like. You got the sphincter here. Okay. Now, in this stomach, the lining of the stomach produces something called intrinsic factor, okay? And it puts it into the stomach acid, okay? And so intrinsic factor, okay, intrinsic factor is needed for the absorption of B12, okay? And so whenever you eat B12, and that's usually through meat or high protein foods, okay? Mostly animal meats is B12. You need intrinsic factor, because without intrinsic factor, that B12 will not bind to anything, okay? And can't be absorbed, okay? And so B12 and intrinsic factor, they bind and absorb here near the end of this stomach into the intestine, okay? And if you don't have intrinsic factor, you can't absorb B12, and that is pernicious anemia. Is a lack of B12. And B12 is important for the maturation or maturing of the red blood cell. Okay? And so without B12, the blood cell can't mature and condense down. So a baby red blood cell is kind of big, right? And it needs that B12 absorbed with intrinsic factor, okay, to be able to condense down into that nice pretty shape that we know as a red blood cell, okay? Without that B12, it can't condense down. And so you end up getting this macrocytic large red blood cell, okay? Same thing with folate. Folate is needed for the DNA synthesis of red blood cell. And so if the DNA can't form properly, and you have a red blood cell that's not quite mature, it's too big, and it's not fully condensed down into its mature form, okay? And so again, that's the role of folate, is for DNA synthesis and maturation. B12 is just for maturation and condensing down the red blood cell. So when you have pernicious anemia, it's common in vegans, common in vegetarians, it's common in alcoholics, because whenever you drink alcohol, alcohol is absorbed directly into the lining of the stomach, okay? You don't absorb it in the intestine like you do most foods. Most foods are absorbed in the intestine, but alcohol is absorbed directly in the lining of the stomach. Okay? And so if you're drinking a lot of alcohol all the time, this alcohol will damage the mucosa in your stomach, and your mucosa is what produces that intrinsic factor right here, okay? And so if your stomach mucosa cannot produce intrinsic factor, that means no matter how much you eat of it, you cannot absorb B12. And then alcoholics tend to have poor diets anyway. They tend to have like poor intake of food. And so it's kind of a combination, but mostly it's because of that intrinsic factor, because their stomach lining is damaged. They often have like a lot of ulcers and stuff like that in their stomach lining. But either way, folic acid deficiency anemia and pernicious anemia, which is a lack of B12, they both, macrocytic because the cell can't mature and condense down. But anyway, so for pernicious anemia, you should be thinking about anybody with anybody with like any GI disorders, especially alcoholics, and then B12 is located in our meat products, so vegans and vegetarians are going to have a lack of B12. There are other B vitamins that you get other ways, but B12 is primarily meat products. Okay? They have the same signs and symptoms as any other of the anemias. The way that you'll differentiate it is it's big, it's macrocytic, okay? And so they're going to have a lot of diet deficiency problems. The way that you treat it is you give them B12 injections, okay? They'll have injections of B12. They'll also have, so whenever B12 is absorbed through the GI tract, you need intrinsic factor, but you actually don't need intrinsic factor whenever you give B12 IM injection. And so if you give B12 via IM route, they don't need it. They don't have to worry about having intrinsic factor or not because it's not being absorbed through the stomach, it's absorbed through the muscle. And so then you wouldn't need that. Okay. Let's see. It has all the same signs and symptoms as all the other anemias. But like I said, it's more common in vegans, vegetarians, and alcoholics. That's really all that's important for you to know about pernicious. Also, the Schilling's test. The Schilling's test is a test that we do to test for pernicious anemia and to try to differentiate from other types of anemia. And it measures like the B12 concentration in your urine. So that part of your study guide that the Schilling's test is about, that's what we're talking about when we talk about pernicious anemia. The treatments are diet replacement or IM injection of B12. And then also treating the underlying cause. So, if they're vegan, they have to take certain vitamins or increase their B12 intake. I think the next one should be folic acid. Yeah, folic acid deficiency. Also, there is a question where you need to know the B12 concentrations. Like I said, it's 2 to 900. Okay. And that question is going to help you differentiate if the patient's having a folic acid deficiency anemia or B12 pernicious anemia, because the B12 and folate will be too low. Okay. So you need to know that B12 concentrations in the blood should be about 2 to 900. What causes a decrease or absence in intrinsic factor? So anything that disrupts the GI, the lining of the stomach. Okay. Assessment findings: they may have frequent stomach ulcers, complain of stomach pain, and then they'll have all the other normal assessment findings that you see in anemia, like pallor, shortness of breath, all that stuff. Okay. What test is used to confirm the diagnosis is a Schilling's test. Medical management: replacement of B12. And nursing management: patient teaching about diet and things like that. Okay. So folic acid deficiency is next. So if your B12 is okay, but your folate is low, that should alert you to a folic acid deficiency. Alcoholics also frequently have folate deficiency. And so what folate does is folate acts in the DNA. And that's why, if you remember, if you've ever been pregnant, or you remember from your OB lectures, you have to do a lot of patient teaching about how important it is to take folic acid. Okay? And that's because folic acid is responsible for the maturation of DNA in all kinds of cells, not just red blood cells. And so in the newborn, if the mom doesn't take folic acid and she has a folic acid deficiency, then the baby will get will not close their spinal tract, and it'll end up being a spina bifida because their spinal cord needs that folic acid to mature and to fully close. Okay? And so pregnant women are also at risk for folic acid deficiency. And that's an important one to know, because if they're pregnant and they're not taking folate supplements, the body will take the folate for the baby and leave mom without it, which means that mom may get a folic acid deficiency. Okay. Again, this one's going to be macrocytic. It's big. It's a big cell. It needs that folate to condense down and fully mature. Okay. Obviously, replacement is just folic acid. Also, you need to know dietary sources of folic acid. Okay. These are things like eggs, meat, okay, things like that. Let's see I don't have very much about folic acid deficiency anemia, just a couple questions. Just know that pregnant women are at risk for it. Then know what kind of foods have folic acid and B12 in them. Let's see. Eggs are also really rich in iron, so iron deficiency anemia patients are going to need a diet high in eggs. Vegans and vegetarians are at risk for both for pernicious and iron deficiency anemia. Okay. That's all I want you to know about that. Assessment findings, like I said, macrocytic cells. Need to know the folate levels, which I mentioned earlier in the other lecture. Nursing management is just patient teaching on folate and replacement. Let's see. Polycythemia vera is our next one. So polycythemia vera is kind of different. You know, we've been talking about anemias and not enough blood and not enough red blood cells. Polycythemia vera is kind of the opposite of that. Okay, it's an overproduction of red blood cells. It's too much. But polycythemia vera is an overproduction of red blood cells. It's genetic. Okay. Usually the treatment, what these people do is, it's not very ethical. Okay. But what these people do is they need to have blood removed. Okay. They need to have, like, every 6 weeks, they need to have about 300 mils at least of blood removed. And so what these patients will do is they will go and they will donate blood. Now, their donated blood is completely unusable. It's got too many red blood cells. You can't give it to people. But donating blood is free. And so it's a free treatment that patients with polycythemia vera typically will do. And they also have a shorter lifespan of their red blood cells. So they're overproduced, but the blood cells don't live as long. And so why that's significant is, like, for example, one time I had a pediatric patient, and the patient was showing all the classic signs of diabetes, okay, polydyspnea, polyuria, polyphagia, and then, weight loss and, stuff like that, all the signs of type 1 diabetes. And so we thought, okay, well, this patient's got type 1 diabetes. We took their hemoglobin A1C, normal. Okay, we're like, oh, that's kind of odd, And so we were really struggling to figure out what was going on, but we hadn't connected the dots. The child had polycythemia vera, and which means her red blood cell lifespan was short. And so that hemoglobin molecule didn't get the full 120 days to get saturated with sugar. Okay, that's what A1C is. It's a measurement of that. And so since that didn't happen for that patient, their A1C was looking normal because their hemoglobin lifespan was shorter. But that's kind of the significance of that. And also, when you have a shorter hemoglobin lifespan, your body's going to have to break down and get rid of more destroyed red blood cells, which can cause spleen problems. They can have their spleen removed at an early age. It can cause, jaundice, bilirubin, liver problems, and getting rid of those dead red blood cells. That may be jaundice. It's a pretty common sign and symptom. Diagnostic findings, they're just going to do a hemoglobin and hematocrit. And the hemoglobin hematocrit is going to be really high because they have too many red blood cells. Okay. The teaching is the treatment is blood removal. That's the only treatment for polycythemia vera, and maybe like an antiplatelet to keep blood from clotting when it's too thick. Okay. All right, leukemia is next. Okay, you got two types of leukemia. So you have ALL and AML. So you have acute myeloid leukemia and acute lymphoblastic leukemia. And remember we said that the cell lines had two branches that they go off of. They are either going to be a myeloid cell or a lymphoid cell, like the T and B cells. So the myeloid cells are going to affect anything that comes off the myeloid stem cell chain. So that means like your platelets, your white blood cells, and your red blood cells. Whereas ALL, acute lymphoblastic leukemia, that's going to affect your T and B cells primarily. Okay. But what happens is it's a defect in the hematopoietic stem cell that differentiates into all myeloid cells. It's basically all the myeloid cells are ineffective or don't work properly. Okay, it's usually older people, AML, whereas ALL can be children and even teenagers or young adults. So if you know somebody in like their 20s that got cancer, it was probably an ALL cancer. Okay? AML is typically over 65. The survival rate for people with AML is pretty low. Let's see, they have a lot of problems bleeding because they don't have any platelets, because that platelets are in the myeloid stem cell line. Okay, you're going to see complications in them like you would a lot of HIV patients, meaning you're going to have like a lot of complications like frequent infections, fever, sore throat. A fever and a sore throat is an emergency in anybody that has problems with their white blood cells. Okay, whether they're on chemotherapy and so their white blood cell production is low, or whether they have HIV or whether they have leukemia, no matter what it is, if they have an underproduction of those white blood cells for any reason, then they're going to have a fever and a sore throat as an emergency for that patient because they can't fight off infection. It's going to overwhelm them. They're going to get septic and they're going to die. Okay? And they're going to have dyspnea because red blood cells are going to be low. They're part of the myeloid line. So they're going to have, shortness of breath, difficulty breathing. They're going to be pale from not having enough oxygen, okay, getting to their skin and that clamping down like we talked about. Pallor, they'll have petechiae and ecchymocosis, which is just like little spots and bruises, okay? Petechiae are tiny little bruises, and that's from not having enough platelets, okay? They're going to have a high number of blasts. When you do a CBC with differential, they're going to have a lot of baby white blood cells because when the body doesn't make enough, it's just churning out everything it makes too early before it's mature. And so they're going to have a lot of blast cells, okay? Neutroblasts, mesonoblasts, things like that. Okay. Let's see, they have lymphadenopathy. They have like their lymph system. They get really, really swollen. Okay. A lot of the times the signs and symptoms of this are just fatigue. And then our primary care provider will draw like a CBC lab. They'll see with a differential, they'll see a lot of blasts. They'll see low hemoglobin hematocrit. They'll see low platelets. But anything on that myeloid line is going to be affected by AML. So you're going to have low platelets. You're going to have low red blood cells. You're going to have low white blood cells. Okay. The treatment is pretty much just a stem cell transplant. That's pretty much it. They also need aggressive chemotherapy. Okay. Let's see. Sometimes they just may be supportive care if they're too old. They have a lot of comorbidities. You may not do a stem cell transplant. The labs that will tell you for diagnosing this is the CBC, leukocyte count, their electrolytes, their potassium and phosphate will be elevated because when you destroy a cell, the contents of that cell goes into your blood. And potassium and phosphate are located inside cells. And so when you're destroying a lot of baby, worthless red blood cells, white blood cells, you're going to have elevated concentrations of those electrolytes that are inside the cell. Okay. And their uric acid will be elevated. They're going to have problems with bleeding, problems with infection, problems with hemorrhage, not being able to clot. You have to decrease the risk of infections. People are always on protective isolation. Okay. No flowers, no fresh fruit, no children. Nobody needs to come near them that might be sick. You'll have to be in full gear whenever you take care of them, like, our PPE. Okay. Fresh fruit is because of organisms that can live on the fruit. Same thing with flowers. Okay. And then fluid and electrolyte replacement, and platelets, blood transfusions, all that stuff. We talked about the absolute neutrophil count. That becomes really important in leukemia. Absolute neutrophil count below 500, you need to be thinking about protective isolation, and that's on your test for the oncology portion. ALL, like I said, it's going to affect our younger children. It's going to be your T and B cells, so they're still going to have a problem with like protecting the body against immune things, immune system invaders. Okay. Usually they give them platelets, red blood cells, hydration. They'll put them on a neutropenic diet, so well-cooked meat, no fresh fruits or vegetables, and then chemotherapy, and they can also do stem cell transplant with them. And this is where your bone marrow aspiration and biopsy comes into play, because if they're suspected of having leukemia, like say their CBC with differential has low red blood cells, low white blood cells, low platelets, and a bunch of blasts, a bunch of neutroblasts, like a high level, then what they're going to do is take a bone marrow biopsy and try to find out what kind of leukemia that patient has. And so that's kind of when your teaching comes in there, and you do have one question on patient teaching when they go home after a bone marrow biopsy. Let's see. You want to protect them from infection as your priority nursing care. Okay. Daily weights and nutrition, okay, because they tend to be cachexic or they have a lot of weight loss. Okay. So there's one interesting exposure that's connected with ALL. We don't exactly understand how, but when you have a virus, it can live in your nerves forever. Okay, like for example, the herpes zoster virus from chickenpox. If you had chickenpox as a child, most of you probably didn't because they have a vaccine now. But if you actually had chickenpox, that herpes zoster virus will just live in your nerves forever. And then when you get older and your immune system's compromised, it'll pop back up in the form of shingles. Okay, so it's the same with the Epstein-Barr virus that causes mono. The Epstein-Barr virus will live in your body forever. And oftentimes, people who have had Epstein-Barr or mono, they will end up developing leukemia. So it's a correlation. You're a lot more likely to get leukemia if you've had the mono virus. Okay. There are also like environmental exposures to chemicals, drugs, radiation, things like that. Also. All right, so that's all about leukemia. Let's see. Multiple myeloma. All right, multiple myeloma is a malignant disease of the plasma cell. Second most common hematologic cancer that there is. Hey, I'm doing a lecture. No. No, I'm still working on it. All right, bye. Sorry, that was Miss Duke's spot. Anyway, malignant disease of the plasma cells. So remember we talked about blood plasma makes up about 50% of whole blood, okay? And this is a disease of those cute little plasma cells. Okay? It's usually older people who get it. And the immunoglobulins in the plasma, the blood plasma, like IgG, IgE, things like that, they are not effective. Okay, so it's mostly affects the patient's immune system. Okay. They'll have bone pain, a lot of fractures, because all these things are produced in the bone marrow. Okay, and their bone marrow is not sufficient to produce good plasma cells, and so a lot of the signs and symptoms come from the bone marrow. So bone pain, fractures, because their bone is really porous, has a lot of holes in it. It's not working well. Severe and constant back pain, arthritis symptoms. But classic is usually back pain, worsens with movement. They'll have a lot of calcium in their blood because calcium is normally supposed to be in the bone, but their bones are very porous and full of holes, and so that calcium kind of leaks back out into the blood. So they have hypercalcemia. And it's also in the bone marrow, the plasma cells are overproducing because the ones that they make are not effective. And so when you have something overproducing in the bone marrow, there's not enough room for other things to produce. So in multiple myeloma patients, there's not anything wrong with their myeloid stem cell line, really. What it is though, is the plasma cells are taking up so much room in the bone marrow. There's not enough room for other places to produce cells. And so you end up getting low red blood cells, low white blood cells, low platelets, just because of a crowding issue in the bone marrow. Okay? There's not enough room to create all of those. Okay? Treatments are radiation and chemo. And they can also do transplants, bone marrow transplants. It's the same for all the other cancers, protect them from getting sick, manage their pain, hydration. Main one is preventing infection. Biophosphonates will help return calcium to the bone. Osteoclasts. So you remember when I said blasts are babies? Okay, so clasts are the building block cells of the bone, osteoclasts. And you have to build osteoclasts, they mature, and they're fully formed bone cells at that point. And so with osteoclasts, the significance of that is they're going to be high. There's going to be a high number because that bone is trying to make up for what the multiple myeloma is doing to the bone marrow. So the osteoclasts will be high. Or I'm thinking blasts. Osteoblasts will be high class. Break down bone. So that's the significance of those. I'm sorry. Assessment findings, frequent infections, back pain especially. Diagnostics, we went over that. Management. Safety precautions is to prevent them from getting an infection. We went over that. There's not a lot on your test about multiple myeloma. Aplastic anemia is when you have a problem with all of the bone marrow. So the lymphoid and myeloid stem cell lines are not working. Okay. Aplastic anemia is like all of the cells in the bone marrow. So you're going to have frequent bleeding, frequent infections, low H&Hs, low oxygen carrying capacity. Aplastic anemia is usually the result of some sort of cancer. Okay. And they'll have low everything. Okay? Low B cells, low T cells, low white blood cells, low platelets, low red blood cells. Thrombocytopenia we need to spend some time on because that's a pretty frequent one on boards. So we're going to move on to thrombocytopenia. But aplastic anemia, primarily you want to worry about the underproduction of red blood cells. All right, so thrombocytopenia is low platelets. If you guys remember, the platelets are 150 to 450, right? Platelets below 50,000 is when we transfuse. Okay, that's when we need to think about giving our patients a transfusion. So, know the difference between papura and petechiae. They're the same thing, but papura is larger. Okay? But they're both bruising underneath the skin. So thrombocytes, what they do is they clot an injured vessel or any injury in the body. Okay? So thrombocytopenia, low platelets means you can't clot. Okay? You can have drug-induced thrombocytopenia, like if the patient's on chemotherapy, or had too much warfarin or too much heparin or something like that. Or they can just have it as, something's wrong in the myeloid stem cell line. Okay? But typically when you have this, it's caused by something. Too much warfarin, too much heparin, DIC, chemotherapy. It's usually caused by something. Okay? You want to avoid injections in these patients because they will not stop bleeding, even from a small injection site. You want to use soft, your patient teaching is avoid injections, use soft oral swabs instead of toothbrushes because their gums will bleed. And avoid introducing anything into the rectum, especially if they're an infant, no rectal temperatures or anything like that, because they can bleed from that pretty easily. You want to look for signs and symptoms of bleeding, so bruising, white tarry stools, vomiting blood, low H&H, any signs of bleeding in the body. Leukemia is a frequent cause of thrombocytopenia. Okay. There's no room for those megakaryocytes in the bone marrow because the bone marrow is so focused on producing a bunch of white blood cells that are ineffective. Okay, so those big megakaryocytes that the platelets kind of break off from, those are underproduced. They look like this, platelets. And So leukemia is a frequent cause of thrombocytopenia. It can be autoimmune, and their own body can attack their platelets. Okay. And then these tend to be stored in the spleen. So when you have a bunch of baby, ineffective, kind of crappy platelets, they'll end up getting stored in the spleen. Okay, because remember I told you earlier, spleen is like your body's trash can. So a lot of the times these people have a splenectomy because the spleen will get overwhelmed with all of these. Okay, so your nursing considerations are going to be bleeding, especially in the brain. So think increased intracranial pressure, hemorrhage, stroke. Bleeding in the brain is a stroke, right? Check their altered level of consciousness signs, any signs of a hemorrhagic stroke, so pupillary changes. In the lung, you want to look for coughing up blood. Okay? For bleeding in the lung, GI, dark tarry stools, skin will be bruising, petechiae, purpura. They need a diet high in iron, B12, and spinach, particularly because spinach is really high in iron. If you have those vegan or vegetarian patients, teach them to eat spinach. It's got a lot of iron. Avoid shaving, use electric razors, use soft toothbrushes, stool softeners, and avoid injuries. You don't want to strain when you have to have a bowel movement because you can bleed from that. So you have to teach them they need stool softeners and try to avoid injuries in these patients. On boards, your test questions are probably going to be about injuries. On the test, or probably be about these patient teaching, like soft toothbrush, no electric, or only electric razors. On your test, though, I'm going to give you lab values, and you're going to have to determine if that platelet count is normal or if it's thrombocytopenic, which means below 150,000. Okay. When we start to transfuse with like cryoprecipitate, which is like concentrated clotting factors, we start that around 50,000. Platelets are 50,000. Okay. Where's my sugar? Okay. Okay. We talked about thrombocythemia, folic acid, anemia, thrombocytopenia, and hemophilia. Let's talk about that one. That's the last anemia to talk about. I bet you guys are excited. So, hemophilia. Okay. Hemophilia is a genetic disorder. Okay. It's a deficiency of factor IX. Hemophilia manifests early in childhood, usually in toddlers. However, patients with mild hemophilia may not be diagnosed until they have a trauma. Okay. And so they're going to have a lot of bruising in hemophilia. It's a deficient in a clotting factor. So it's kind of like thrombocytopenia. You'll see the same signs and symptoms, but it's not the thrombocytes that's the problem. It's that cascade of clotting factors, and they're missing factor IX, which is important in blood clotting. Okay. It's more common in boys. The gene for hemophilia is on the X chromosome. Okay. They have a lot of bleeding in the joint spaces. They'll come in with a swollen knee and maybe fatigue, and that's how you find out they have bleeding in the joint spaces because they're hemophilic. Okay, and they're just having a lot of bleeding. They can't clot. So they're going to have bruises, maybe intracranial hemorrhage, frequent nosebleeds, blood in the urine, and then joint swelling. And then you have the other signs and symptoms of anemia like tachypnea, tachycardia, and hypotension. Okay. Causes are it's genetic. They're X-linked characteristics, so dad usually passes it on, and males are usually affected. Okay. It can happen spontaneously. For these patients, you need to provide a lot of emotional support. You know, they can't play sports and stuff like that, especially in children. That's a big deal. You need to put cold, especially if they're bleeding in the joints. Cold will help shrink those blood vessels. Okay, so it's easier for the body to clot. Pain control. Signs and symptoms of decreased oxygenation, like restlessness, anxiety, confusion, pallor, cool, clammy skin, chest pain, decreased urine output. To avoid heavy lifting because they can strain and start bleeding from that. Notify the doctor of any minor injuries. They need to avoid NSAIDs and aspirins because they have antiplatelet. Also, over-the-counter nasal decongestants, avoid those. Avoid herbal treatments. because they can further interfere with the clotting process. Dental extraction, when they go to the dentist, their dentist always needs to know. And then nasal packing doesn't really work very well with these patients because as soon as you remove the packing, they start bleeding again. A lot of the times what we'll do is we'll soak nasal packing in like vasopressin or epinephrine or something like that. And then that will help kind of hunt down the blood vessels in the nose if they're having frequent nosebleeds. Treatments are going to be replacing those clotting factors, especially with cryoprecipitate, or you can even give them a specific factor. They can isolate that and give that to them. Desmopressin or vasopressin, like I said, may be used to stop bleeding. You can give them synthetic collagens, glucocorticoids for joint pain and swelling, so steroids. Okay. Usually daily steroids and clotting factors. You take an H&H, it'll be low, usually. Platelets are normal. You'll have a prolonged PT and PTT, which are your bleeding times. Okay. It's inherited on the X chromosome, so male. Assessment findings, bleeding into the joints is most common, but any kind of bleeding or bruising. And that's all I have for 31. Really. The next one is lymphatic disorders. Stop this recording and we'll have a new one for that. You can take a break if you want to for a few minutes, and then we'll just spend a few minutes on lymph, and then we're done.